Hello and welcome to the Clinical Care Options podcast series, a closer look at evolving treatment strategies for rheumatoid arthritis. Today's episode, taken from a recent symposium, is on putting patients first. In this episode, Dr. Stanley Cohen, Dr. Sheetal Desai, and Dr. Eric Ruderman discuss how a treat-to-target approach can help. They also give practical tips on how to make shared decision-making easy. If you want to follow along with the slides, just go to the show notes and click on the link. You can also find a link to additional online education on RA from Clinical Care Options. So let's get started and hear about putting patients first, starting with Dr. Sheetal Desai.
So treat to target. We all know that without targets, it's really difficult to deliver high quality care. And in the field of medicine, treat to target is not new. It was pioneered by cardiovascular medicine with the Joint National Committees, the ATP guidelines. Diabetology came in the 1990s with their diabetes control and complications trial and their UK PDS trial, showing that tight control of glucose really made a significant difference in their patients. And we've been really lucky since the onset of the biologic and small molecule era in rheumatology, specifically with rheumatoid arthritis initially, that we've been able to think about treat to target. Joseph Smolin introduced the whole treat to target, bringing it to rheumatoid arthritis in 2009 in his pivotal article. And many of us have already heard it quite a bit. And many of us are implementing targets in our clinics. So we are lucky to practice in this era, and there are multiple targets that people look at between clinical remission and low disease activity, depending on your patient population. And the best way to measure this is by having a target. You won't have a diabetes patient come into your clinic and they will always know their hemoglobin A1C. And it's quite nice because they understand when it's closer to 6 or 7, they're doing great. And then when it gets closer to 8 or above, they're not doing well and they need to control it better. And like a hemoglobin A1C is in diabetology, we have disease activity measures, and putting it all together in one number helps summarize the disease activity of a patient. It allows patients to understand it better. It helps improve compliance and then hopefully improve patient outcomes as a result. Based on the 2019 ACR recommendations, we have a multitude of disease activity measures to choose from the DAS, the CDAI, SDAI, RAPID-3, and the PASS scores. Note that there are differences in all of these scores, and some have strengths based on the patient population you work at. And so these are the differences that many of you are aware of. And just speaking from experience at University of California, Irvine, we have a good number of patients that are part of the Medicaid program that don't always get labs before they see us in clinic. So for us in our clinics, the ones that are easiest to actually use are the CDAIs and the RAPID-3s, because they do not require the use of laboratory tests that need to be resulted by the time we see the patient. The DAS scores and the SDAI scores both need laboratory data. But all of these disease activity measures have been proven to work and are efficacious regardless of which one you actually use. And they use a combination of patient characteristics, physician input, as well as laboratory tests with some of these measures. So just like you've seen, we have so many options of therapies. And the most updated guidelines we have are the 2015 ACR guidelines for treatment of rheumatoid arthritis. As you heard earlier, we're looking forward to the 2020 guidelines premiering at this meeting. But thus far, this is a snippet taken from the 2015 guidelines for treating rheumatoid arthritis. If you just kind of look at the level of evidence of many of our guidelines are low, some moderate, some high, but really low. And so how do you take the multitude of options out there available to patients and decide what the best option for your patient is? And that's by actually combining it with patient preferences. So I'm going to take you through a case of mine that I had a couple of years ago. This is Sarah. She's a 47-year-old female with seropositive erosive rheumatoid arthritis. She had already failed methotrexate, leflunomide, sulfasalazine, hydroxychloroquine, and had failed 2 TNF agents with etanercept and adalimumab. She had a history of breast cancer, fortunately was quite focal, and was treated in 2017 with lumpectomy and radiation. And when I saw her in clinic in January of 2019, at that time she was on methotrexate 20 milligrams subcutaneous, prednisone requiring 15 milligrams a day, which is much higher than we routinely use for rheumatoid arthritis. But she was working at our medical center and could not function at all. And she had actually received and finished a rituximab cycle 3 to 4 months prior and was still not noticing significant efficacy. She was reporting 2 hours of morning stiffness, pain and swelling in her elbows, her MCPs, and her ankles. And for her, did not have labs the day I saw her, so we chose to use a CDAI. We added her swollen joint count, her tender joint count, her patient global score and physician global score, and the unadjusted value came out to 30, which puts her in a high disease activity state, which made it quite clear that a change in her therapy was needed. Now, when you're looking at this patient of mine here, you see that she's failed much of the conventional synthetic DMARDs that we use in this era. She's failed 2 of the TNF mechanism of action. She's failed rituximab, has high disease activity, is using a dose of prednisone that is not good for her to be using long term. And the comorbidities that she had that we had to really think about and was forefront in her mind was obviously her malignancy risk because she had already had early stage breast cancer. And then the timing of the next agent we will use in her because of her 3 to 4 month prior history of rituximab. And so when it comes to shared decision making as a concept, we really need to realize that this is a collaborative process where both patients and clinicians need to make treatment decisions together. It doesn't work when the patients say, Dr. Desai, go ahead and please make the decision. That's not the correct way to do it. You need to integrate evidence provided by the physician along with patient preferences. And sometimes it's not always easy, depending on the age of the patient, the cultural background of the patient, but we need to try really hard to draw them out. Because what we can see here is a good decision for a patient is one that is informed, one that is consistent with their patient values. And if they're informed and the decision they make is consistent with their values, it's more likely to be acted upon. We have all seen pharmacy claims databases that show that no matter how much we think our patients use either conventional synthetic DMARDs or biologic DMARDs over time, that the refill rates do substantially decline. And a lot of this actually comes down to how comfortable the patients feel with their drugs and how much it is a good decision for them. So shared decision-making is an interviewing technique that involves at least 2 parties, so between yourself as the clinician and the patient, and you might have a support person there. In some of our clinics, we have a pharmacist that joins us. Other clinics might have an auth coordinator that joins them, but you need at least 2 parties between you and the patient. Both yourself and the patient need to actively participate. So this is where you need to draw the patient out. Even those patients that tell me, please go ahead and make the decision. Tell me what you think is the best option for me. I have to often ask them to weigh in on whether they like pill forms, whether they prefer injectables, whether they have the time and the ability to actually come in and do an IV infusion. And so it's very important to actually try to draw them in. So we share data about the benefits and the harms and the costs of these medicines to the best of our knowledge. And then we hope that the patient, or we invite the patient to share their values, their preferences, the stressors that are going on in their life, and what's most conducive to them about the attributes of the treatment. And once both of us are able to share that, then you can agree on a treatment decision. And so just to kind of go over this case, what I historically used to do in clinic is I'd take a piece of paper and I would just sit there and I would write all the therapeutic options for rheumatoid arthritis on the top of the paper. And then I would just quickly jot down the pros and the cons and things they have to be aware of with each therapeutic option. And that often takes a while. So when I did this with this patient in early 2019, because she had already tried 2 TNF drugs, she was not excited to try a third. And I supported her in that decision. She had already failed a trial of rituximab. And at this point, the other options that were available were abatacept, tocilizumab, and the JAK inhibitors. We at this point had 2 JAK inhibitors that were on the market, and these were the 3 options she considered. But you can see with the data that Stan and Eric so eloquently covered in this section, you can see that if we're trying to discuss all the trial data and the plethora of information to patients, it can get overwhelming. it's often difficult enough for us to remember the select trials and the choice trials and which ones were done with which drugs, even though we've gone through them and we understand them. But to really give a bird's eye view to patients is actually quite difficult. And so the question really becomes is how do we translate clinical trial evidence to our patients so they understand it and they can make a uniform decision based upon that. And so our patients all have different levels of health literacy. They have different cultural backgrounds they come from. Their age, their general medical conditions can actually impair their cognition. And the key really is to simplify the complex concepts that we have from our clinical trials with ACR 20s and 50s and 70s, and then taking the risks and the serious adverse effects that are commonly seen and trying to walk our patients through a lot of this. And one technique in doing that is a decision aid. And that's what I'm going to actually introduce you to. And I hope that you find it useful. So a decision aid is a neutral informational tool. It helps guide your patient towards a good decision. It's the same tool. It is consistent and standardized across all of your patients. So it is not specific to that one patient. It helps provide specific probabilities on efficacy, on safety, to help your patient compare different options and make a decision. And the huge selling point is patients can take it home. It allows them and encourages them to actually reflect on what you discussed, to think about it with their significant other, with their children, and then go ahead and make a decision. And I feel like early on in my career, I would try to make a decision with my patients right then and there in the clinic. And I found over time, increasingly, I've asked the patients to actually go home. We'll try to hone in on two different options. And then I'll often ask the patients to go home and really think about what option is best for them after discussion with their significant others. And then just message me back, and then I would put that option through. So I'm going to take you through a decision aid that a colleague of mine, Dr. Richard Martin from Grand Rapids, Michigan, actually put together. He does a lot of research and has a huge interest in shared decision making. And this is a decision aid that he initially put together that I've actually just kind of tweaked and updated over time. And I'm going to walk you through it because I would highly recommend considering using something like this in your clinical practice. Please note that this decision aid is free for clinical care and you do not need a license to use it. And we would encourage you to copy it, download it, and keep it and tweak it as you see fit. So if you see on the top of the decision aid, what you have here is the basic characteristics of the drugs. So this is a decision aid for a patient with rheumatoid arthritis that is considering starting their third DMARD, which is the case in my patient. She'd already failed 2 TNF DMARDs, biologic DMARDs, had also failed rituximab biologic DMARD, and she's now looking at her third DMARD. And here you have on the top the different options available to the patient. You have the year of FDA approval. You have the frequency and how it's given. So the patient can see at a bird's eye view whether it's an infusion, whether it's an injection or infusion, whether it's an oral route, and they don't have to worry about coming in or administering an injection. Then I'm going to kind of take you through this table here where the next part of the table is the benefits, and that's what we call it, the potential benefits. And this is where we translate the clinical trial evidence when it comes to ACR 20s, 50s, 70s. I mean, those are very difficult for a lot of clinicians to be able to articulate exactly what an ACR score actually means. And many of us in our clinical practices don't even use ACR scores. So you can imagine how difficult it would be to translate this to the patient. But if you take your ACR score and you call it the power to achieve improvement, and then if you actually look at your change in radiographic damage when it comes to the modified Sharp score, and you actually call that the power to slow joint damage, what you can see going back here to the decision aid is the benefits in terms of the ACR 20 score and the ability to slow down radiographic progression are presented in more of a general fashion, where this score right here, which is called the power to suppress arthritis, is actually the ACR 20 score from the pivotal phase 3 trials of that drug. So as you can see here, what you translate to the patients is 60 out of 100 patients will improve versus 52 out of 100 will improve versus 56 out of 100 will improve. based on their ACR 20 scores. And if a patient is looking at this across the board, they see that the power to slow joint damage when it comes to radiographic progression is pretty equivalent amongst all of these biologic DMARDs and small molecule inhibitors that are discussed here. So the first part of this table, again, is the basic characteristics of the drug. Second part of the table is how do you translate the benefit to the patient? And these are really simplistic ways that can be borrowed to actually translate the benefit of an ACR 20 or the improvement in their SHARP scores. Now, often the most important thing to patients are what are the harms of this agent and what are the risks to them. And so these are the serious infections that are reported in their pivotal clinical trials, other adverse effects that might be rare, and then special population considerations when it comes to breastfeeding, when it comes to pregnancy, when it comes to TB risk evaluation, when it comes to coexistence of other viral infections. And so the next part of this decision aid is really focused on the harms and almost a higher degree than the benefits, because this is actually what patients really are concerned about. So you can see the serious infection rate as it was reported in the pivotal phase 3 clinical trials as events per 100 patient years of use is taken out here. So patients can actually look across this whole board and see, okay, the rate of serious infections, the number of events is actually quite low and varies regardless of what agent we're going to look at, anywhere from 3 to 6 events per 100 patient years. Then we talk about the side effects and the kind of risk factors that we worry about from agent to agent. When you're looking here, for example, with the JAK mechanism of action, we bring up the ability to increase your liver tests, increase your lipids, decrease your blood counts. It may cause blood clots, as was seen in the baricitinib and the tofacitinib trials that were actually done. And then we have special population considerations here, where we talk about caution with pregnancy or avoidance of use in different populations of patients. So all of this is quite relevant to patients, and you can kind of walk them through and talk about which ones are rare, which ones are more common, what you have to be aware of as you actually treat patients. So for example, when you're talking about B-cell depletion, I might bring up PML, but I might bring it up in a way to say that it's extremely rare. It has been reported, but very rarely seen, especially in an RA patient population. And the last thing to actually talk about are the practical issues. And these issues vary depending on what city, region, state, and even what country you guys are practicing in. I know the majority of the people in this session are in the United States and Canada, but we have our colleagues that are in Central America, South America, Europe, and the Asian countries. And really a lot of this varies from country to country and region to region. And so I purposely left the cost part here blank. But depending on the kind of patients you see and the costs that it actually represents for them, you can actually have your auth coordinator actually fill that in, or you might be able to kind of gauge what generally is the first line, second line, third line agent with the majority of your patient population. And then the safety monitoring is on here as well, because that's important to patients to know whether with certain agents they need to get blood work on average every couple, 2 to 3 months, or whether they're looking at blood work once or twice a year in a yearly TB test. So going back to my patient, I actually hand wrote this when I actually did this for her, but had I done this with the decision aid, we would have talked about it and we would have crossed parts off. We would have said, okay, listen, you've already been on 2 different TNF drugs. We're going to cross off the TNF mechanism of action. She had already tried rituximab, so we would cross off that mechanism of action. At this point, she was left with abatacept, tocilizumab, and the JAK MOA. And for her, when we discussed the serious infections and when she kind of thought about it, she felt most comfortable with abatacept and the JAK MOA. She actually went home with the paper that I wrote all of this on, and within several days contacted me and decided to actually continue on with oral tofacitinib in this case. But just kind of as we go through this, I just want to highlight the shared decision-making is a process that's a lot easier said than done. We're often very busy in clinic. Sometimes the patients ask the questions right when we're about to walk out of the door, and it's probably the most important question they want to ask us. And actually having something like this, a decision aid, I have one that's for a patient with RA considering starting their first DMARD. I have one for second DMARD. I have one for third DMARD. We now have ones for psoriatic arthritis that Dr. Martin has created and I've actually adjusted over the years. And I have one for my lupus patients as well. So this actually helps us tremendously to be able to have a very uniform way to present information to them in a very succinct way that they can actually understand and in a way that they can take home and reflect upon. And again, these are open for you guys to go ahead and use without any permission needed at all. We really want you to consider copying these, tweaking them to as you see fit for your patient population. And I know it's not easy to do. Like I said, often the hardest questions we get as we're walking out of the door. But the key is we want our patients to make a good decision. And a good decision is one that's acted upon their preferences. And if they make a decision based on our data and their preferences, they're most likely to be able to follow through with that decision and continue on, hopefully. So we will go ahead now to the question and answer part of this session. And I don't know if Stan, or you or Eric have had a chance to look through some of the questions that may have come in that we can help address. I
took a look. Let me. I want to be cognizant of the time because we want to make sure we are aware of that for people. Because it's been a long day, but I think we have time to handle a couple. Let me actually start with one that's a bit of a segue from something you just mentioned, Sheetal, and that was logistically monitoring and the monitoring burden of some of these agents as part of the decision-making process. So the question was, in terms of JAK inhibitor side effects, how frequent is the monitoring recommended for the patients on RA doses? And I'll turn to you, Sheetal, and Stanley, if you have a different opinion, but how often do you tell people they need to be monitored on these agents?
Initially, and Stan, you can let me know what you think, but I do it very similar to what I do with methotrexate. So initially, when they get on these agents, I am checking labs a little bit more frequently within weeks to a month after they actually start the drug. But by the time they have been on drug for some time, I'm often going closer to the 2 to 3 month mark with CBC and a CMP.
Yeah, I agree with that. And again, if you look at the package inserts for upadacitinib and baricitinib, the guidelines or recommendations from the FDA are not really specific. It just talks about monitoring labs as part of the standard of care. With tofacitinib, it actually says every 3 months. So I think every 3 to 4 months is appropriate down the road.
And then how often are you guys doing lipid panels?
I typically do it 3 to 6 months after I start to see if we've had anything. And if they're good, then not all that frequently. If there's any question, I might follow it up again a few months later, or at least engage their PCP on whether they need therapy at that point.
I do a little earlier, but generally just do it once. I mean, the effect's going to happen or not happen, and just so we can work with the primary care to get it managed.
Okay,
great.
Maybe we'll take one more here, and this is actually a broad question. I'll throw out to both of you. Should JAK inhibitors now be used prior to anti-TNFs and in specific patients, and if so, which kind of patients would you do that, or at least recommend it?
Yeah, it's a great question. I know we discussed it earlier this morning at the great debate as well. And I don't think there's a correct answer to this question. It really depends on your level of comfort. I will say I was a biochemistry major in college. So when the JAK MOAs came out, I was very concerned and very cautious with using the MOAs because I knew how pervasive the JAK-STAT mechanism of action is in intracellular signaling. But I will say over the years of using them, patients have done quite well. And I'm very comfortable using them first line versus a TNF MOA at this point. I don't know if I have the correct answer for every patient because at the end of the day, there are a lot of patient preferences. And so like Dr. Weinblatt brought up this morning, you get some patients who love the fact that you have 20 plus years of data with anti-TNF MOAs and sometimes prefer that because of known safety and known length of data over JAK-STAT MOAs.
And just to finish with the T's, we'll see what the new recommendations are on Monday. Will there be a level playing field for post-methotrexate or JAK inhibitors to biologics, or will there not be?
Mm-hmm.
I mean, I've gotten to a point where it's fairly level in my practice. I think this is an option for people who failed methotrexate. I was a little bit skeptical early on because we all had patients who were quite comfortable using injectables because that worked for them. And, it's easy to use a medication that works. They weren't daily injections, so it was easy. But as time has gone on, I certainly see more and more patients say, if I could just take a pill once a day and not have to give myself a shot, I'm all for that. So I think it's a bit patient specific, but I'm seeing more people who would prefer to do oral agents than shots than I thought in the past.
I think the other thing, once we finish up, is that with other indications for these medications like psoriatic arthritis, axial spondyloarthritis in the future, possibly lupus, atopic dermatitis, they're going to be ubiquitous. And so I think everyone's going to be a lot more comfortable with it.
Yeah.